Well, hello, everyone. My name is Noah Raizman. I'm from the Centers for Advanced Orthopedics here in Washington, D.C. And the topic of tonight's lecture is Dupuytren's contracture. And this is going to be a broad overview and updates of what the most current evidence is in 2021. So I have no disclosures for this talk. So just quickly, an introduction about myself. So I am a hand and upper extremity surgeon. I specialize essentially in shoulder to fingertips as well as peripheral nerve reconstruction. I did my undergraduate training at Brown University and went to medical school at Columbia. And I subsequently came to DC in 2006 to begin my orthopedic residency at GW, and then went away to do a fellowship in specifically hand surgery and peripheral nerve reconstruction at the Cleveland Clinic. I've done research at Harvard Medical School, at the NIH, and University of Pittsburgh, and NYU. And really, my practice focus, in addition to just general hand surgery and peripheral nerve surgery, is evidence-based practice and evidence-based medicine. I'm the outgoing chair of our National Hand Society, ASSH, their evidence-based practice committee, and I serve on the similar committee for the American Academy of Orthopedic Surgeons. And so I'm involved in the creation of clinical practice guidelines and appropriate use criteria, and really trying to promote the use of the best evidence for medical decision-making. And I'm also a member of the Ethics and Professionalism Committee for our National Hand Society. And this is my family, and my daughter Maddie, and son Finn, and wife Courtney. So I have published recently, this article is actually in press right now, on Dupuytren's disease and what the hand surgery practitioners around the country know about what the current literature suggests. Some things are surprising in that it turns out that with our questionnaire, a significant number of hand surgeons came up with incorrect answers on some of the evidence-based questions that we had for them, but probably 80% of the questions, a wide majority of hand surgeons knew the correct answer for. So Dupuytren's disease, first of all, named after Guillaume Dupuytren, who was a French surgeon during the French Revolution and Napoleonic era. He was the chief surgeon at the Hôtel de Dieu, or House of God, which was the most famous hospital in Paris. Among other things, he was famous for taking out Napoleon's hemorrhoids. There are many things named for him. Dupuytren's disease, which is named for him, was probably not operated on by him first, nor identified by him first. One of his rivals from across the pond, Sir Astley Cooper, an English surgeon, operated on it previously. So it could be called Cooper's disease, but we stick with Dupuytren. It is a genetic condition that affects the palms. It involves mostly people of Northern and Western European descent. It is, however, not a Viking disease, despite what it's called colloquially. It is more common in males. There typically is a strong family history, and the older you get, the more likely it is to be prevalent. It is an abnormal thickening of the palmar fascia. And the palmar fascia, which I'll show you some pictures of later, is the tissue that holds the skin down to the underlying structures in the hand. Everybody has palmar fascia, but in Dupuytren's, it thickens abnormally and becomes contractile. So it's characterized by pitting of the skin in the palm, the evolution of nodules, and eventually cords. And as those cords get larger and thicker, the joints of the hand begin contracting. It is not typically painful, but it can be very functionally disabling. And this is what it looks like when it really starts. You can barely see the evolution of some small nodules here. And over time, those nodules thicken, you start getting pitting of the skin in the palm, and eventually thicker cords that begin bringing the finger down into contracture. It's hard to determine the prevalence of Dupuytren's contracture because of the large amount of geographic variability and the fact that people present with various degrees of symptomatology. It can occur in nearly any population. We hypothesize now the genes involved in Dupuytren's contracture spontaneously mutated somewhere around 1200 AD in Northern Europe and made their way through the population. But now it has spread throughout most parts of the world. It's more common in men than women, but only slightly so. Most patients will present over age 40, but that's not universal. The role of smoking and diabetes and alcoholism in the progression of disease is somewhat debatable. Some studies have suggested a relationship, some have not. There are two associated conditions, what we consider ectopic disease. So Dupuytren's that happen somewhere else. They are related to similar pathology. One is a Lederhose disease, which is named after someone named Lederhose, not after Lederhosen. But this is Dupuytren's disease that affects the soles of the feet. Peyronie's disease involves the formation of plaques in the penis that can cause it to veer off to one side. Lots of famous and well-known people have Dupuytren's or had Dupuytren's, from Mitt Romney, Frank Sinatra, Margaret Thatcher, Ronald Reagan, Bill Nye. Many people have seen ads for Xyaflex with John Elway, but this is a very common disease, and many well-known people have lived with it. So Dupuytren's disease involves the thickening of the palmar aponeurosis, and the cell type responsible for that are called myofibroblasts, which end up pulling down the soft tissue of those cords and making it contractile. And over time, you get progressive flexion of the fingers into the palm. There's always a balance in soft tissue between collagen synthesis and degradation of collagen. This is how our cells remodel and heal. And in Dupuytren's, that balance is distorted, and there's increased production of fibronectin and different types of collagen expression. And these proliferative tissues connect the dermis to the underlying structures. So one thing that's important to know about Dupuytren's disease is that once you have it, the presentation is highly variable and progression is unpredictable. Some people will present with a nodule in their 30s and 40s, and it will not go anywhere for 20 years. Some people will have fairly fast progression. We hypothesize that trauma and repetitive use can make this worse over time, but it's still hard to predict. There is one subset of patients with Dupuytren's that tend to have more aggressive presentation. And this is what we term the Dupuytren's diathesis. Now, most patients will present in their 20s with bilateral disease, ectopic disease, including Peyronie's and Lederhose. And the picture here in the middle is a picture of Lederhose disease. And they also typically will have knuckle pads. Most of the Dupuytren's findings are on the palmar side of the hand, but knuckle pads are over the PIP joints, which you can see on the right side of the screen. So when you start thinking about treatment, it begins with the nodule. Most nodules are not painful at all, and rarely you get what I consider to be a bit of a princess and the pea phenomenon, in that a nodule, when you're doing heavy gripping or grasping, will concentrate forces just underneath that nodule. And in those cases, the nodule can be painful. There is some evidence that splinting and hand therapy can improve pain control, but it does not really affect progression as far as we know. It just really has not been studied well. There are some small studies, case series, that support injecting cortisone into the nodule. It does change the collagen expression in the tissue, and over about 4 to 6 weeks will soften the nodule somewhat. It's unclear whether in the long term this will prevent progression of the nodule into cords. The main side effects, because you're injecting it superficially, are some blanching or lightening of the skin and some thinning out of the fat underneath the skin. And what we really don't know is how many injections you should do. The one most popular study suggests 3 injections at 6-week intervals. But again, this is empiric and not really supported by comparative studies or high-level evidence. By the way, I forgot a little housekeeping at the beginning. If you do have questions, I'm happy to go through as many as I can after the lecture. Please put them in the Q&A function, and I will get to them once we're done. So when does Dupuytren's need surgery or other types of intervention? I see a lot of patients who have something in their palm, and either their internist sends them to me, or on their own they seek out the care of a hand surgeon, largely just to know what they're dealing with. Probably 1 out of every 3 or 4 patients that comes in for Dupuytren's doesn't need any intervention at all. They just need to be reassured, to understand what the disease process is. So when do you need treatment? For insurances to authorize treatment, you need to have a positive tabletop test, which means, can you get your hand flat on the table? If when you try to do that, you can't quite get down, you're probably ready for treatment. Most insurances will authorize treatment when you have a contracture here. These joints here are called your MP, or metacarpophalangeal joints, of over 30 degrees. Now, most of us can hyperextend these joints. So if you can only get it flat, you're probably already close to a 30-degree contracture compared to your other fingers. But if it's really starting to pull down, that's usually when you need treatment. The next joint down, these joints here, called your PIP joints. And your PIP joints tend to get very stiff if left contracted. And so any PIP contracture is an indication for treatment. What else is going to prompt people to seek out treatment? Well, when it starts interfering with your ability to do things, when it's catching, when you're trying to put your hand in your pockets, when it's interfering with your grip, or when the cosmesis is bothering you. This is a progressive condition. We have no medical cure. There is research ongoing, and hopefully at some point we will have a medical treatment for Dupuytren's. But at this point, all we do is play whack-a-mole. So the cord comes up in one place, we take it out, cut it out, separate it, try to make it go away, but it will pop up later, either in the same place or somewhere else. Overall, there are only a handful of major treatments for Dupuytren's, and we'll go over them, but you need to individualize, because some contractures are going to be more amenable to one type of treatment than another. Some that are particularly dangerous are contractures at the pinky PIP joint, because with Xyaflex, they have been the area where flexor tendons have ruptured. They're also very close to the nerve and artery, which can be easily injured during closed treatments. and sometimes surgery is the best option for these. Contractures of the last joint, the DIP joint at the tip of the finger, are difficult to treat safely with some of the minimally invasive treatments. Spiral cords tend to push the blood vessel and nerve in and towards the surface of the skin, making them at risk with these techniques. So it all depends on what your surgeon is comfortable doing and what their experience has been. And then it comes down to patient preferences, because there are some differences between the overall recovery, success rate, recurrence rate, and there's a lot of balancing that one has to do. So your four major treatment options here are going to be open surgery, needle aponeurotomy, Xyaflex, and a device called a Widget, which is an external fixator. So Xyaflex is an enzyme treatment. It was originally derived from the bacteria that you can see in the center picture here cause gangrene. And they isolated the enzyme that dissolves collagen from it and purified it and studied it extensively. And this is a procedure that can be done in the office setting. You prepare the enzyme, you inject it into the cords, and then you wait anywhere from 1 or 2 days to 3 or 4 days, come back in, numb up the hand, and massage the cords and stretch them out, and they will pop. So here's an example of Xyaflex from my friend Mark Vitale in New York. This patient had about a 65-degree MP contracture and 25-degree PIP contracture. This picture on the right is about a month after the Xyaflex treatment, with excellent reduction of the contracture. Now, the early studies on Xyaflex suggested very high success rates, better at the MP joints than the PIP joints. The less contracture you had, the better you did. However, all of the follow-up studies and comparative studies have suggested a high recurrence rate of at least 40 to 50% at 3 to 5 years. Now, it is a treatment that can be repeated, but it's not atraumatic. The disadvantages of Xyaflex, everybody will get pain at the injection site, swelling, and significant bruising. You can get skin tears. A very minor one is pictured in the bottom middle photograph here. But the picture on the left is what almost everybody's hand is going to look like right before manipulation, and it typically looks worse after. You can get lymph nodes that are inflamed in the elbow and the armpit. That's not uncommon. The two complications that one has to really worry about are large skin tears, which can take several weeks and sometimes even months to completely resolve, and a rare complication, which is flexor tendon rupture. Basically, the enzyme will dissolve the collagen in the cord, but it could also dissolve the collagen in your flexor tendons. And the picture in the bottom right is from one of the first published case reports on this phenomenon. And the patient had a PIP cord to the small finger injected by a very good and talented hand surgeon, and ended up with a ruptured flexor tendon that needed surgical reconstruction. So the next option here is needle aponeurotomy. And my colleague, Charlie Eaton, performed thousands of these. Gary Pess performs thousands of these, and they are widespread. Once you learn how to do them, they're fairly straightforward. Some people are a little more aggressive than others, but this is a minimally invasive technique where you only numb up the skin and you take the bevel of a needle and use that as a little saw to go back and forth until the cord is ruptured. And the potential risks here are to the nerves and blood vessels. You have to repeatedly ask the patient if they feel any twinges of sensitivity or burning pain. But this is something that can be done relatively safely, particularly for these big cords in the middle of the palm. What the technique does is just cuts a hole in them. So it doesn't get rid of any of the tissue. With Xyaflex, you kind of melt away some of the tissue. And here, you're just making a separation, which gives you a break in the cord. It can be repeated. It can be done on multiple fingers. And overall, the results are very similar between needle aponeurotomy and Xyaflex. So this study, several years old by Gary Pess, with a minimum of 3-year follow-up, showed that only about 30% maintained the correction of their PIP joints, but almost 3/4 maintained the correction of their MP joints. The older you were, the better the maintenance of correction when you had needle aponeurotomy. But again, it's something that can be repeated fairly easily, and it's considered also fairly cost effective. So the advantages are it can be done in an office under local anesthesia. It doesn't make a big tear in the skin. It doesn't get as bruised or swollen as Xyaflex, so it's an overall shorter recovery. And you can do both hands consecutively, and it is more cost effective than surgery or Xyaflex. But the contracture occurs more rapidly, though it's, with all the comparative studies we have, almost identical to Xyaflex. You can't fix pitting skin or capsular contractures effectively, and there is a risk of nerve injury. Now, probably the most popular option, and for legitimately good reason, is surgery. And what you see on the left is typical Dupuytren's cords, a pretendinous cord towards the bottom of the screen. You can see wrapped in blue on the left side, the digital nerve wrapped around a spiral cord, which thickens as you get towards the PIP joint. And what you see on the right is after resection, you've got a straight finger and you're looking only at the flexor tendons. So the advantages of taking out the Dupuytren's tissue, which is called a fasciectomy, are that you can get all visible signs of disease out of there. It's the only technique where you can really get rid of the Dupuytren's tissue. It is definitely time tested, and it has the lowest recurrence rate by far. The reported recurrence rate for surgery is anywhere from 4% to about 20%, versus at least 35 and more like 50 to 60% with either needle aponeurotomy or Xyaflex. It also gives you more treatment options and versatility. The disadvantages, you have an incision that then needs sutures and wound care. Overall, a slightly longer recovery, though in my experience, it's not all that different between surgery and Xyaflex. There are some studies that suggest that the complication rate may be higher. However, the biggest study we have is from the National Health Service in the UK, which studied 120,000 patients with Dupuytren's disease. And it showed that the overall complication rate of surgery was only 1.2%. Overall, there are higher costs, but it's been very hard in cost analyses to really look at recurrence rate and disablement and come up with reasonable numbers on the actual cost. So yes, it is more pricey as a single episode, but when you look into recurrence rate, it probably pays for itself. But that data is still forthcoming. Now, in terms of what you can do surgically, there are things you can do in surgery that you just can't with any other technique. If somebody has a chronic contracture, it's not just the Dupuytren's tissue that's holding everything down, it's also the joint itself is contracted. And the only way you can really address that is with a capsular release surgically or using a digit widget, which I'll cover in a moment. You can deal with loss of skin in a chronic contracture by doing a skin graft or doing skin rearrangement. In the top right, you see a technique called a Z-plasty, which allows you to treat a longitudinal contracture. And in the bottom right, you see a skin graft taken from either the forearm or the base of the thumb. These heal in very well. And where you put in the skin grafts, they actually have a lower recurrence rate. You can even leave a portion of the wound open to granulate in and eventually heal in. You have to treat it with local wound care, but overall recurrence rate is very low. That top left photo is an example of this, what we call the McCash open palm technique. So one other option that you have, which can be used in conjunction with either of the other treatments, is using an external fixator. This is called a digit widget, designed by a hand surgeon and engineer named John Agee. And you put a couple pins into the finger, and you have this contraption that you see at the top right that hooks into a little wrist brace, and you use a series of rubber bands over the period of 6 to 8 weeks to improve your contracture, very similar to braces for your teeth. And Digit Widget can give you some very good correction for difficult contractures and recurrent contractures that might be difficult to treat otherwise. Here's an example from one of my colleagues. Here are the pins going in under fluoroscopy. The patient had prior surgery, did not have a good soft tissue envelope, and had a 65-degree PIP contracture, which you can see here. This is what it looks like with those pins in and the device attached. And here he is about 3 months. He had the device on for 2 months while it was actively reducing the contracture. Then you let it settle for a week or two, and then you take out the pins. So in summary, your treatment and your adverse effects can depend on severity of disease, but you really need to tailor the treatment to the patient. There are differences in time expenditure, cost, and what's safe and likely to work the best. Recurrence is likely. This is a disease that we cannot cure. We only treat it, and we do our best to get your hand as functional as we can, but the understanding is that it will likely recur in some form over time. And most methods provide good outcomes with minimal risk. And thank you for your attention, and I will start going through some questions in the Q&A. So our first question is taking up pickleball a bad idea for somebody with early Dupuytren's? It's an interesting question. Dupuytren's is a disease that has incomplete penetrance. So even if you have the genes for it, only some people are going to develop the disease, and only some are going to have severe disease. Just because you have nodules doesn't mean they're going to progress to cords, and it doesn't mean it's going to progress quickly. We do hypothesize that repeated use of the hands, heavy gripping, can worsen it. And actually, when we see patients with Dupuytren's who have an unrelated surgery, say a trigger finger release, carpal tunnel release, it's very common to see a worsening of their Dupuytren's. That being said, I think that the treatments we have are largely very, very good and very reliable. And so I wouldn't limit your life in order to prevent Dupuytren's from progressing. I think picking up pickleball, if it's going to be something that's enjoyable for you, just live your life normally, and whatever happens to your Dupuytren's, we can fix it. The next question, Dupuytren's often co-occurs with trigger finger. How would you manage early Dupuytren's and trigger finger in the same hand if the trigger finger has already been treated with cortisone? So if you have a trigger finger and you're essentially ready for surgery, and you clearly have Dupuytren's cord overlying it, it makes sense to take out the cord at the same time. You can get some recurrence even through the scar tissue there, But I think that doing a limited fasciectomy at the same time as a trigger release is usually the way to go. You can also just do the trigger release and essentially tempt fate and see what happens. But if you are staring at the Dupuytren's tissue, there's really very little reason not to take it out when it's staring you at the face or in the face. So is ultrasound guided needle aponeurotomy on the horizon? Absolutely. The question is, how necessary is it for a pre-tendinous cord in the palm? It's so superficial relative to the nerve and vessel that it doesn't really make much sense to use ultrasound. Where I think ultrasound has a role is in the more difficult to safely reach cords, the spiral cords, which are kind of right here at the junction of the palm and the finger. Those are areas where the nerve and vessel are displaced. And so I think people are already using ultrasound to help guide their needle aponeurotomy. Holding the ultrasound probe there makes doing the procedure a little bit more futzy and difficult. So if you are not a very experienced ultrasonographer, it can be difficult. But I think absolutely that is the way that we're going, and there are a lot of people already using it. But it's only useful or necessary in limited cases. The next question, I currently have only a nodule with a small cord at the bottom. Should I just monitor it or be treated before it gets more serious? Again, this is where the tabletop test is your indicator. If the nodule is not painful, you leave it alone. If you are at the point where it's catching when you put your hands on in your pockets or catching on things and you cannot get your hand flat on the table, it's probably time to have somebody look at it. Does insurance cover surgery? Absolutely, and without a doubt. In Europe, I think that it's getting harder and harder to get approval for Xyaflex just because of the cost relative to needle aponeurotomy. But I have never seen surgery not fully covered by insurance. So next question is, I had radiation therapy to both palms and had significant regression of the cords and nodules. Is this treatment one that you refer patients to? So almost all of the literature on radiation therapy as preventive treatment has occurred in Europe. It has not reached widespread adoption in the US. And one of the biggest reasons is that there are several potential complications to radiation therapy. One of them is inducing a malignant tumor called a sarcoma. The younger you are, the greater lifetime risk of radiation therapy inducing a malignant tumor. Also, radiation therapy in and of itself can cause burns, skin sloughing, and contractures. What we really don't know is the long-term results of radiation therapy, and we do not know how to adequately balance the risks and benefits. So that has made me personally hesitant. A good friend of mine is the chair of radiation oncology at Hopkins, and we've discussed it, not in a while, but we have discussed it in the past. Certainly, if there's a pressing reason, if you have Dupuytren's diathesis, and it may be an option. However, I think that the hesitancy that we see amongst hand surgeons in this country is warranted, given the risk of inducing a tumor. I've been treated with Xyaflex 2 or 3 times, and my pinky finger is worse than before. What would you recommend now? It's 90 degrees. I think in that situation, you're really looking at surgery in most cases. If you have significant recurrence, even after Xyaflex or needle aponeurotomy treatment, it does not preclude surgery. Surgery, you can open things up, you can find your nerves and blood vessels and tendons, know exactly what you're looking at, and it can treat the actual capsular contracture in a way that the other treatments cannot. And you can also use skin grafts and other things to prevent recurrence and to make sure you're not fixing it too tight. So I would say surgery is probably your next bet there. Is Dupuytren's and trigger finger the same thing? No. Trigger finger is a completely separate condition. It does not involve contractures. What it is an inflammatory nodule that sits on the tendons that pull your fingers down right at a level here where those tendons go through a little tunnel, and that nodule catches on the lip of the tunnel and then pops through. The presentation of trigger finger is tenderness right here in the palm and a click of the tendon as the nodule pops through. So not at all the same thing as Dupuytren's. And the last current question I have, I've had 2 Xyaflex treatments for pretty bad Dupuytren's on the ring finger of my right hand. The first attempt was not successful. The second attempt was more successful, but not perfect. Also have a 30-year-old cord in my left palm, so far with no bent finger. At the end of the day, if you got some improvement with Xyaflex, you can always repeat it. If it does come back, it can be repeated again. But overall, the expectation is that a very significant proportion of people will have a recurrence after either Xyaflex or needle aponeurotomy. So I think it's important to realize that with open eyes and realistic expectations. Is it really obvious to a patient getting needle aponeurotomy when tingling and burning are caused by the procedure? It seems like this could be pretty nerve-wracking for the patient, and you could just be tingling out of anxiety. Honestly, in my experience, it's not like that. If you're getting close to the nerve, you will know. I don't think it's easily mistakable, especially when you put a little numbing in there. You'll feel a little vibration as you go through the cord. Again, this is all dependent on where the cord is and how close the nerve is expected to be, but I think you can do this very safely without provoking a lot of anxiety. So if you really want to not provoke any anxiety, have surgery because you get to go to sleep for it. In some cases, the surgery can be done under local anesthesia, but in most cases, it's still done under general. So that's all the questions we have. Thank you so much for your time. And I also want to thank my colleagues, Mark Vitale and Teresa Pianta and David Way, who helped me with some of the slides for this. If you have any questions, please feel free to get in touch with me. Our office is 18th between K and L downtown. And Kathy has our contact information if you have any issues, but you can look me up pretty simply.